Many patients have already had it done, and many more are asking for it. But does testing the MTHFR gene do any good? Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue. Welcome to part 3 of our folate series, where we're doing a deep dive into the gene that activates folate in the liver, MTHFR. There are 2 common variants of this gene, C677T and A1298C. And like most genetic tests, the promise with MTHFR is big, but what it delivers is more complex. Patients are already coming in with the test done, often through naturopathic clinics, and determine that MTHFR is the explanation for all of their psychiatric problems. That is unlikely, but MTHFR does play a role in depression. MTHFR mutations increase the risk of depression by about 40%, and they are more common in depression. In the general population, the rate of major MTHFR problems is 30 to 40%, but patients with depression have a higher prevalence, around 60%. These mutations are even more common in people of Hispanic or Mediterranean descent. But MTHFR is not a black or white issue, as hematologist and folate expert Victor Hoffbrand explains.
It depends on dose. It's not an all or nothing. If you give enough folic acid, you'll certainly get plenty of methylfolate made, even in those people. They don't have a complete block, otherwise they wouldn't be alive.
Last week, we explained that L-methylfolate has better data in depression than folic acid, and that MTHFR problems may be the reason why. But if Dr. Hoffbrand's theory is right, you could get the same result just by upping the dose of folic acid. So far, though, that has not been studied. Back to our question. Is it worth testing the MTHFR gene in depression? One company that offers this test is GeneSight, and they only test for one of the variants, the C677T polymorphism, not the A1298C. That is still important information. C677T predicts a greater risk of depression. What is missing is whether it predicts response to methylfolate. The methylfolate trials did not compare people with or without the gene, and there are many other factors that predict response to methylfolate and don't cost anything to assess.
Clinical trials have found that patients with obesity, a BMI over 30, or inflammation, measured by a high sensitivity CRP over 3, are more likely to respond to methylfolate. During inflammation, the body uses up more folate, and it also doesn't absorb well, so serum levels tend to be low. Obesity changes how folate is distributed throughout the body and also lowers serum levels. Besides, obesity is often an inflamed state. Other predictors of methylfolate response are risk factors for low serum folate, like renal failure, gastrointestinal disease, alcohol use disorders, especially liquor drinkers, smoking, eating disorders, and poor nutrition. Also, a host of medications that mess up folate levels and metabolism. Lamotrigine, valproate, carbamazepine, phenytoin, oral contraceptives, methotrexate, metformin, sulfasalazine, warfarin, and triamterene. We spoke last week about how folic acid can interfere with lamotrigine, but there is no evidence that methylfolate does, and in a small randomized trial of bipolar depression, adding methylfolate 15 milligrams to lamotrigine improved mood without causing any mania. So the MTHFR gene is just one of many factors that may point to a methylfolate trial. And since this vitamin is low cost and very well tolerated, it's often best to try it and see. Start with 15 milligrams a day. Get a depression rating before starting it, like with the PHQ-9, and again a month later. If there's a difference, long-term supplementation might be in order.
Folate is a B vitamin, but what exactly is a vitamin? Vitamins are organic compounds that the body needs in small amounts but cannot produce on its own. There are 13 vitamins: A, C, D, E, K, and another 8 that are grouped in the B family. Folate is part of that B family, which includes thiamine, B1, riboflavin, B2, niacin, B3, pantothenic acid, B5, pyroxidine, B6, biotin, it's good for the hair, B7, folate, B9, and cobalamin, B12. The B vitamins play important roles in enzyme functions. That's what they all have in common. Deficiencies of most B vitamins are associated with depression, although we only test routinely for thiamine, that's B12, and folate, B9, because these are the most common deficiencies out there. In cases of B12 deficiency, it's best to defer to the primary care physician for treatment there, as some patients are not able to absorb the B12 vitamin and are going to require injections.
One B complex vitamin we think is worth knowing about is N-Light. This branded product is FDA cleared as a prescription food supplement for depression. It contains a low dose of L-methylfolate, 7 milligrams, and also includes folic acid, folinic acid, B1, B2, B3, B6, and B12, as well as other nutrients with potential benefits in depression: iron, magnesium, zinc, coenzyme Q10, and omega-3 fatty acids. Although the doses included are low, N-Light attempts to deliver them in more potent bioactive forms, and there's a remarkable clinical trial that shows it works.
This 2-month trial is remarkable because it tested N-Light on its own, without an antidepressant. It was a large trial, and it achieved a large effect size of 0.9, enrolling a mix of untreated depressives and some who had failed antidepressants. So far, this sounds too good to be true, but there is a catch that harkens back to that genetic test. All of the patients in this trial had depression and MTHFR abnormalities, either the A1298C polymorphism or the one that we more commonly test for, C677T.
We're impressed with that because of the large effect size, and because N-Light contains many ingredients that are known to treat depression on their own. N-Light costs around $90 a month and is available through the manufacturer's website at nlight.com or through most e-scribing platforms. Patients may be able to get a month trial free through the website, and if they are taking other supplements that are already in N-Light, like omega-3, they may be able to save costs by stopping them. N-Light's manufacturer JMac Pharmaceuticals also makes a version for peripartum depression, Embrace HR, which is identical to N-Light except for its marketing. It's a promising direction for women, but so far Embrace HR has only a small open-label trial in peripartum depression. Time for a preview of the CME quiz for this episode. Start earning CME for each episode through the link in the show notes. True or false? Methylfolate is converted into SAMe.
We started this podcast series with the hope of finding simple causes of depression that are due to deficiencies. Folate certainly meets the mark here, but when you get into the metabolic details, it gets kind of complex and hard to follow. So thank you for sticking with us through the end. It's a complex area that is always changing, and I need to offer up an important update on that note. A few years ago, at the Carlat report, we printed a piece suggesting that SAMe is one of the most effective natural treatments for depression. That was true based on the studies we had at the time. SAMe is one of the chemicals in the folate cycle. L-methylfolate converts into SAMe, so in many ways SAMe functions just like methylfolate, increasing the monoamines, serotonin, norepinephrine, and dopamine, and decreasing that depressogenic chemical homocysteine. But since then, new studies have come out that were negative for old SAMe in depression, including a new meta-analysis that made it come up really wanting. Well, the problem here is that most of SAMe's studies were not placebo-controlled. They used active drugs as controls, including tricyclic antidepressants and SSRIs. Now, when something goes head-to-head against a tricyclic antidepressant and works, that seems impressive. But remember, the placebo effect is bigger than any antidepressant effect. And if the placebo is particularly strong in a study, it might wash over any med effect and make all treatments look equally positive, which might have been what it did with SAMe.
I think of it as looking at a wallpaper in bright red light. The red light in this analogy is the placebo. It's powerful. It overpowers to different colors in the wallpaper, making everything look more or less red. Likewise, even effective antidepressants can look about as good as a dud when the placebo effect pushes both treatments in the study.
What Kellie just said there is called a failed trial, when the situations and scenarios of the trial make the placebo effect so powerful that you can't even tell if the drug worked. So all this is one explanation for SAMe's failures. The bottom line in this new analysis of the research is that SAMe did not work so great in studies where it went against an actual placebo, but it did work in head-to-head drug comparisons, which are not as good a point of data to rely on. And the bottom line is that it suggests SAMe doesn't do much at all and is not one of our most powerful natural treatments. On the other hand, the studies here are many. There are over 24 of them. Most are small, so we don't really have definitive answers, and SAMe is involved in the same pathway that methylfolate is. So there is a possible explanation for how it might work in depression, and maybe it does work. We just can't say for sure at this point, and the data is not as positive as it is for L-methylfolate, so we're moving L-methylfolate up and SAMe down.
Let's focus on the SAMe trials that did include a placebo arm. These are a mix of positive and negative, with more negative trials in recent years. When averaged together in a meta-analysis, SAMe looks no better than a placebo. And one reason for this inconsistency may have to do with the molecule itself. SAMe is more temperamental than most supplements, requiring blister packaging to protect it from heat and moisture, and enteric coating to prevent stomach acids from degrading it.
On balance, I'd say that SAMe probably works, but that the data is not as firm as it is for methylfolate, and since both address the same pathway, I would go with methylfolate. SAMe does have a role for patients with depression and medical comorbidities. It has good studies in osteoarthritis and fibromyalgia, and some studies in liver disease, Parkinson's disease, dementia, and HIV as well. SAMe targets specific areas of these diseases through its anti-inflammatory, antioxidant, and neuroprotective properties. Most convincing in those studies are the ones involving osteoarthritis and fibromyalgia, where SAMe relieved both depression and pain in large randomized trials. The analgesic effects were comparable to those of NSAIDs. For the other medical comorbidities, the benefits are less clear, and what we know is drawn from preclinical studies and small clinical trials.
SAMe can also reduce sexual side effects on antidepressants. SAMe is very well tolerated and safe, and it has been safely combined with most classes of antidepressants, including the MAOIs, although in theory, the MAOI-SAMe combination could cause serotonin syndrome. If you use SAMe, start 400 milligrams QD, raised by 200 to 400 milligrams every 3 to 7 days to a target dose of 800 to 1600 milligrams QD. Take on an empty stomach for better absorption. Dr. Aiken has links to lab-tested products on his website at chrisaikenmd.com/supplements. They are just links to products on Amazon and the like. He doesn't sell them directly or profit from them. SAMe costs around $40 to $80 a month, and a lot of brick-and-mortar stores have 2-for-1 sales on them.
And so we end our folate journey, the little vitamin that an underappreciated scientist discovered from a bowl of Marmite in 1931. From there, it grew to industrial production as a spinach extract. Doctors started measuring folate in the 1960s, and they found many patients were lacking, particularly those with depression, schizophrenia, and dementia. Supplementation with folate helped, especially when people didn't respond to antidepressants. And patients can now get the bioactive form at a pretty low cost, methylfolate 15 milligrams a day.
Along the way, SAMe got involved sometime in the late 1970s, promising to boost levels of serotonin, dopamine, and norepinephrine. And it probably works, but with its mixed trials and fragile composition, we recommend starting with methylfolate.
Folate is one of the rare examples in psychiatry where you can treat depression by addressing a known deficit. When it was first discovered, we thought that was the whole story, and used folate to augment antidepressants when the serum levels were low. But we've learned that there are many reasons why people might respond to folate supplementation. The MTHFR gene is one of them, and there are probably other factors as yet undiscovered. The bottom line? Well, the bottom line is this. Methylfolate treats depression with the same effect as an augmenting antipsychotic like aripiprazole, around 0.3 to 0.4 if you're into effect sizes. And if your patient has the MTHFR deficit, like about half of people with depression do, that effect size is even bigger, in the large range, around 0.9. Methylfolate has well-designed large trials, and unlike the antipsychotics, it addresses a known dysfunction in the pathophysiology of depression.
And unlike antipsychotics, it doesn't cause tardive dyskinesia, diabetes, weight gain, neuroleptic malignant syndrome, arrhythmias, akathisia, anticholinergic effects, sedation, or temperature imbalance.
Oops, we forgot to mention hypotension, falls, sexual dysfunction, and hyperprolactinemia.
So, on balance, we think it ought to be moved up in the treatment algorithm. The problem is that patients may not believe it works in our pharmacocentric culture. So it's up to you to give that placebo boost. And if that means matching the treatment up with a low serum level or an MTHFR test, good on you. Victor Hoffbrand is Emeritus Professor of Hematology at University College London. He has authored over 700 scientific articles and chapters, several textbooks on hematology, and the 2023 book, The Folate Story, A Vitamin Under the Microscope. Like the podcast? Share it with a friend. Use the arrow button in your podcast player, or write us a review. We read every one of them. And if you have topics you'd like to hear about, let us know at asktheeditor@thecarlatreport.com. The Carlat Report is one of the few CME publications that depends entirely on subscribers. Thank you for helping us stay free of commercial support.